For our next segment, I invite Dr. Dakshitha Wickramasinghe, consultant surgeon, to deliver his lecture on wound dressings in general practice. Dr. M.R. Hanifa and Dr. Pushpa Veerasinghe will continue to chair this segment as well. Thank you.
While Dakshitha comes up and gets ready with his presentation, and before I introduce him formally, let me formally welcome all of you who are online at the moment. I think there are about 170 to 180 online right now. So very good morning to you and welcome. So in keeping with general practice, what we see in our clinics all the time, we never know what will walk through the door, the next patient. So we move from cardiology to a very, very important part of our practice, which is wound care. And it is my extreme pleasure to introduce a colleague of mine from the University of Colombo, Dakshitha Wickramasinghe. He's a senior lecturer in the Department of Surgery with us, and he's a consultant surgeon at the NHSL. And he has a very extensive curriculum, CV, ranked first in order of merit. So, and in the Part 2 MS exam, received the Postgraduate Institute Gold Medal in Surgery. I think he's following our chief guest here today. And I can tell you he is a prolific researcher, which I know personally. So, and his special interests are, of course, in wound care, and he has his... Over to you, Dakshitha.
Good morning, ladies and gentlemen. Thank you, Chairperson, for that flattering introduction. And I'd like to thank the organizers for inviting me for this session. And my topic today is going to be on wound dressings with a special focus on how to select an appropriate dressing when a patient comes to you. I have no conflicts of interest that are related to this lecture, but I have to warn that this presentation contains names of products, and some of these are trade names. I unfortunately can't avoid this. We don't have generic equivalents for all these products. And another thing is these are products that I'm familiar with. That doesn't mean that other products are bad. So I want you to understand the principles of using these dressings, and you're free to choose whatever dressings you seem fit. And this is the overview of my presentation. I'll talk a bit about the basics of dressing and quickly move on to the bulk of my presentation, which is how to choose a dressing. Then we look at a few special situations like burns, which don't really fall under that classification, and look at individual dressings and the history of dressings as time permits. So healing is the body's normal response. If there's an injury, the body will try to heal. If the wound is not healing, that means there is one or more factors that is prolonging the healing. Now, chronic wounds are arrested in a state of inflammation. This might be contributed to by infection, and there may be other factors. And it's very important that you identify why a wound is not healing so that you can make sure your patient improves with your treatment. So a very philosophical way of looking at dressings is you try to provide the patient and the wound with a factor that is necessary for healing but the wound lacks, or remove a factor that is harmful but is in abundance in the wound, and protect the wound. So the purpose of this, my brief talk, is to tell you how to make sure an acute wound doesn't become a chronic wound, and if there is a chronic wound, how you can make sure it heals soon. So very briefly, a dressing is a sterile pad or compress that is applied to a wound. That's all that is. In use, we talk about two things. It can be a primary dressing and a secondary dressing. A primary dressing, for example, is something like this pad in the Tegaderm pad dressing, which is in direct contact with the wound. Depending on the wound, which I'll touch upon later, you want to give the appropriate characteristics to that wound. A secondary dressing is something that is not directly in contact, and that is chosen to supplement your primary dressing. Sometimes the primary dressing may not stick well, and then you need an adherent dressing to make sure this dressing stays in place. And So for example, if you have a patient coming with an abrasion or a wound, you might use something like a fusidine towel or a Vaseline gauze to make sure your dressing doesn't stick. Now that's a very good non-adherent dressing, but it has zero absorbent capacity. So if the wound is having any exudate, that dressing is not going to help. So when you're using something like that, your Vaseline gauze will be your primary dressing, and you will use some like dressing gauze as a secondary dressing, and you might put a band-aid or plaster on top of that. So all of those become your secondary dressings. And depending on your usage, some dressings can be used by themselves. They don't require a secondary dressing. And also in certain situations, the same dressing which became a primary dressing in one setting would become a secondary dressing in a different setting. We'll see this as we discuss different examples. So the first thing to do when a patient comes to you with a wound is to assess. Basically, you're assessing the wound as well as looking at the other problems, a multidisciplinary assessment. When you're assessing the wound, you're trying to see the diagnosis and the baseline characteristics. Now, the biggest problem for the patient might be the wound, and the most obvious problem that you see might be the wound, but there are a lot of underlying factors that are propagating this problem. So, is there enough blood flowing to the legs? Or is the patient having peripheral vascular disease? Or the opposite, is the patient having varicose vein, and is there venous congestion? The wound is not going to heal unless you correct the underlying factor. And then you need to note the wound bed condition. That is going to be the biggest part of this talk, and I'll get to that in the next few slides. And it's very important that you record the wound type, location, and size. When I was in training, the only way of doing this was to use some graph paper and draw the wound, color it, mark where the areas were. Now everyone has a decent mobile phone with a camera. It's a very good idea to take sequential pictures. And that achieves two things. One, it tells you that what you're doing is working, and you know if things are not, and if the same thing, for example, if the wound has slough, this is not improving, you need to deal with that. And also, when you're seeing the patient, you can show them what has been done and how the things are changing. The second is the multidisciplinary assessment, and that is, I haven't put it in the sense of having a team and a meeting in a hospital sense, but these are the factors that you need to consider if a wound is not healing in one of your patients. Are there surgical issues? Are there callosities? And is the patient not keeping the foot flat? Is there, like I said, not enough blood going to the feet? Is there diabetes? No amount of wound dressing is going to heal a wound if the sugar is not under control. And also, is the tissue and the wound, the tissue around the wound viable? Now, we don't have many wound care or tissue viability nurses, but this is what they will consider if they were there. If, like you'd see in the next few slides, if there is non-viable tissue, they need to come off. Physiotherapy and podiatry, again for lower limb wounds, about weight bearing, offloading, and pain. And most importantly, the family and the carers, because you will deal with the wound in your clinic, but they will have to manage the patient and the wound at home. So again, I've listed these components in the multidisciplinary assessment, not to indicate that you need to get all of them into your clinic and deal with it, but at least give them a thought about the factors that may be propagating the chronic wound. The second step is to correct any underlying problems. Again, like what I said, the wound is the most obvious problem, but there are a lot of invisible underlying problems. The wound is only the tip of the iceberg. So again, glycemic control, make sure their sugar levels are good. Nutrition can be both obesity as well as malnutrition. Macronutrients like protein, micronutrients, iron, vitamin C, all of these are important. Edema, especially in lower limbs. If somebody has chronic edema, and if this is not settling, the wound is not going to heal. That interstitial fluid is just going to leak out through that wound, and that by itself will make sure if everything else has been taken care of, the wound doesn't heal. Continence. If a patient is incontinent, a perineal wound or a pressure ulcer is going to be impossible to heal. So there are situations where we have often, not very often, but we have had to even have a defunctioning colostomy to make sure the pressure sore heals. Vascular issues, pain, mobility, and non-compliance. Patients often come and tell you, give me a tablet, give me a dressing, and make sure it heals. But they don't want to do the simple things like offloading, using proper footwear. So it's important that you emphasize these in a patient with a wound that is not healing. So this is probably the most important slide, or the most important consideration, and if I've managed to put anybody to sleep, I'd like to, for the other person seated next to you, to wake them up. So the most important thing in assessing a wound, in selecting a dressing, is looking at the wound bed. So there are 4 components in wound bed preparation, and each of these components deal with a different pathophysiological problem in the wound. And the International Wound Bed Preparation Advisory Board has given an acronym which is very easy to remember, TIME, time, to remember these. So when you have a patient who has a wound that is not settling, these are the factors that you need to consider. Tissue. How is the tissue in the wound? Is there infection? Is there inflammation? How is the moisture? Is it too wet? Is it too dry? And how is the wound edge? Is it advancing as appropriate? Is the wound contracting? Is it epithelializing? So when we see a wound that is not healing, there is one or more of these factors that are underlying. So the dressing you choose will depend on what we need to provide or what we need to remove from the wound. Right. So when you see a wound, what's happening there? Is it dry? Is it necrotic? Is it non-viable tissue? Is there inflammation? Is there infection? Is the wound wet or dry? Or is the edge not advancing despite doing all of this? Now, if a patient comes to you and has a wound like this, what would you think, or how would you describe this appearance? It's not uncommon. So it's dry, it's black. So this is a typical Eshka. In comparison, if you have a wound like this, so it's yellow, there's a lot of non-viable tissue, it looks moist, it's not as dry as the left one, but they share something in common. Both of these, and any wound that looks like this, has non-viable tissue. So if you have a patient with a wound with non-viable tissue, that devitalized or non-viable tissue needs to come off. This tissue doesn't have a blood supply, and that tissue itself will not heal. And not only will that tissue not heal, it will delay the healing of the underlying wound, and it will prevent reepithelialization. So that tissue needs to come off. It can either be a sharp or a surgical dissection, scissors, scalpel, anything you're comfortable with, or dressings, which promote autolysis. Because these wounds are dry, the autolytic enzymes in the wounds can't act optimally. So the dressings we use will optimize the autolytic activity. The third option is larval or maggot or biological debris removal. It's available in Sri Lanka, not commonly done for various reasons, including acceptability to patients, but it is an available option. And there are situations where larval therapy works very well. So these are the options of removing non-viable tissue. I'll get to the use of Intrasite and Idorsorb in a bit. But basically, irrespective of what mode you use of these, you need a wound that looks like this at the end. There is no dead or dying tissue, there is no slough, and the wound bed looks clean. And that's a wound that you can help heal. It will granulate sooner, and you can deal with it easily, versus a wound that's on the left. The second type of wounds that you might see are wounds looking like this, where the obvious underlying problem is an infection. So infection is a spectrum. You might have contamination, where it's a few bacteria on the surface of the wound, not causing much trouble. You might have colonization, where there is active multiplication of bacteria, but they've not really worked their way into the wound. Or you might have local infection, where the bacteria are present in deeper tissue, spreading infection, where it's spread beyond the wound, and systemic infection. Now, in an otherwise healthy person with a good immune system, contamination and colonization does not require any intervention from you. The natural defense mechanisms will take care of those bacteria. On the other hand, if there is localized infection, spreading infection, or systemic infection, we need to do something. So the dressings we use in infected wounds can either be iodine-based, silver-based, or antibiotic dressings. So iodine-based dressings are probably something that everyone's familiar with. There are 3 main types. We don't have the third type available in Sri Lanka. So the ones we have are either povidone iodine-based or cadexam iodine-based. Povidone iodine, the commonest one we know, the trade name is betadine, is iodine bound to a synthetic polymer known as povidone. And in an aqueous medium where there is moisture, this iodine is released from the polymer. The problem with povidone iodine is that it has very sharp rises in the iodine concentration when it's applied to a wound. So it's good, it's antibacterial, it works against most bacteria and organisms, but the problem is this peak is also toxic to the host cells. So that is not a characteristic that you really want in a wound dressing. So unfortunately, there are studies that show using povidone iodine on wounds may even delay the healing because of that toxicity into the host cells. Cadexam iodine is different in that there are starch molecules or starch granules on which iodine molecules are placed. In contrast, cadexam iodine has a much more longer and a static acceptable level of iodine into the wound, and I'll describe why that happens. So because of that, it's not toxic to the host cells, and that has, in addition to killing off the bacteria and the organisms, it actually promotes healing in the wound. The third group of iodine base are liposomal povidone iodine, which we don't have in the local market. So, like I said, cadexam iodine is a starch molecule or a granule on which iodine molecules are adsorbed. So this has multiple actions. When you have applied cadexam iodine, it absorbs moisture from the wound. So this is very useful in wounds that tend to have a bit of exudate. And as these starch granules absorb the moisture, it maintains the moisture in the wound at an appropriate level. So that facilitates wound healing. The second thing is, as these granules become bigger and as they absorb water, the iodine molecules are released and the iodine ions are released. So there is a gradual controlled release of iodine, which is antibacterial and keeps the wound clean, but also non-toxic to the wound and the host cells. The third thing, what these granules do as they swell up with fluid, is they have microscopic movements, and that improves or that helps in removal of slough. You'll see when you apply these to wounds, especially wounds with slough, by the first or the second wound dressing, the dressing change, you don't need to do anything for the slough. Most of that slough will come off, and you'll see it in the demonstration video I will show. So it is said that a gram of cadexam iodine can absorb up to 7 milliliters of fluid. And this allows you to keep the dressing up to 2 to 3 days. So the patient doesn't require frequent wound dressings. It's very easy and convenient for the patient as well. So there are several preparations. One is a powder, which is convenient because you can use it for most types of wounds. But you also have gel or tube form or cream form, as well as dressings like a mesh dressing that you can place. So if you have a wound, I mean, I've taken this off the website of the manufacturer. If you have a patient who requires cadexamidin or Iodine, that's the powder form that is most frequently available. So this is an ideal wound to be using cadexamidin. It has a bit of slough, a bit of exudate. You don't want to be frequently changing dressings. And there is not much slough for you to take the patient to theatre and start cleaning. So once you clean the wound, you apply the cadexamidin and get about a 3 millimeter depth of cadexamidin. That's about the depth you want for it to work. That orangeness comes from the iodine on that starch. So cadexamidin, like I said, is the primary dressing. It's in direct contact with the wound. And you need to use an appropriate secondary dressing to A, keep that in place, and B, also to protect the wound. Right. So after about 3 days, you can take it off. And once you remove the dressing, you'll actually see that that orangeness is gone. It's actually become a very pale yellow. So that is fine. That means that the iodine has been released and the granules are still there. And as soon as you wash it, you realize the slough, or most of the slough, will also come off without any active intervention on your part. And for most patients I deal with who I use Iodine, every 3 days a dressing change is enough to take care of the infection and slough. Moving to silver dressings. So silver has multiple actions. It acts on the cell wall and disrupts the cell wall of bacteria. It works in the cytoplasm and inhibits the cellular respiration. And it also acts on the DNA and the RNA and prevent bacterial multiplication. And it's very important to realize it's the silver ion and not the silver atom that actually works. So it requires a moist wound environment. If the wound is dry, putting a silver dressing is not going to work. And it's also important how you moisten it, because you have to use distilled water or sterile water in moistening. If you use normal saline, the sodium ions will interact and interfere with the silver ions, and that is not something you want. So there are different silver dressings. The commonest dressings available in the market are Atruman silver and Acticoat. Both of these are a very thin mesh form of a dressing which don't have much absorbent capacity. So if you have a wound that has a lot of exudate, you might want to use something that has a foam backing, or at least use some gauze on top of it. So if you're using a silver dressing, this is the first thing, and this is the most important thing you need to do. You need to moisten it with sterile water and leave it for about 2 minutes to completely soak. If the dressing is dry, it's not going to work. And you place it on the wound, and again, you use an appropriate secondary dressing to supplement this. If you're expecting a lot of exudate, there has to be a secondary dressing that can absorb that. And some dressings can be left for 3 days. Some, like Acticoat 7, can be left for 7 days. Obviously, like the previous speaker, take a common sense approach about how long you will keep it. But generally, 3 days should be fine, unless it's a very bad wound. Antibiotics, the common ones are fusidine impregnated wound dressings, like the fusidine tule, and metronidazole. Now, metronidazole gel or Metrogel is a very good wound dressing. I use it a lot. But remember, it's not an alternative to hydrogel. It may look like a gel, but it doesn't share those characteristics of intrasite. Use Metrogel as much as you want, but know its purpose. Don't try to replicate Metrogel or intrasite by using Metrogel. Metrogel is cheap. It's a good dressing if you want to cover a wound, but it's not a replacement. The second or the third problem you might see in your patients are moisture imbalance. It might be a wound like this, where there is insufficient moisture. It's a dry, low exuding wound, and you need to provide a dressing which provides a wound with moisture. And these can be hydrogels, hydrocolloids, and medicinal honey. Now, all these 3 types are available in the local market. So if you have a wound that you want to use hydrogel, you need to clean it and to dry up the surrounding. And you use hydrogel to get at least a 5 millimeter thickness layer, a 5 millimeter thick layer onto the wound bed. Otherwise, there's not enough hydrogel for it to work. If there is a cavity, use a gauze to pack it. And that will make sure that hydrogel is applied evenly onto the surface. And you cover all of this with a secondary dressing. And so that was a gel form of a hydrogel. You also have sheet forms that come in prefabricated shapes and sizes. When you're selecting a dressing like this, make sure there is about a 2.5 centimeter or 1 inch overlap in each direction. So once you pick the right size, these come in different shapes. If you have sacral wounds, they come in a C shape for the sacrum. And you apply it and make sure you apply it all around so that you get an even application of the edges. I'm just fast forwarding the videos in the interest of time. And once you remove these application sheets, you should have an airtight closure from that adherent layer. So the other thing I want to emphasize is when you're trying to remove this, what you need to do is you need to remove this adherent dressing from all around before you try to take it off. Otherwise, you're going to damage that skin, which might be macerated. So before you start peeling off from one side and go straight across, make sure it is loose from all directions, and then you can just lift it off and it'll just come. Don't try to peel off one side and go straight across the wound. So the second type of wounds, or second moisture imbalance you will have, are wounds that have too much moisture. They're too wet and have too much exudate. So these wounds need either foam dressings or negative pressure wound therapy. So foam dressings are dressings, again, these happen in bed sores. You might have rope type dressings or sheet dressings, and you take it and you keep applying it into the wound. Now, these dressings absorb moisture and they will get bigger. So don't try to pack it very tightly, because it's going to be very uncomfortable for the patient. As the dressing expands with moisture, the wound is going to be very painful because it's getting bigger and bigger. Same thing with sheet type dressings. You have two options. Either you can cut it to shape or you can fold it in. The problem with both these dressings is that they will not stay by themselves. So you need to apply an appropriate secondary dressing to keep them in place. So the final one is a non-advancing edge. So once you've dealt with infection, inflammation, moisture imbalance, and once all of that is corrected, if the edge is still not advancing, meaning there is not enough wound contraction and not enough reepithelialization, that is when we have a non-advancing edge. This, unfortunately, is not very easy to deal with. The best form would be negative pressure wound therapy, but we are not in the practice of using this at a primary care or home setting. It can be done, it is done worldwide, but we have still not come there. So a small word about topical antiseptics. Now these are things we use in different situations, things like hydrogen peroxide, bleach, and acetic acid. They have been used historically, they have their role, but they also have a potential toxicity to the host cells. They increase the inflammation and decrease epithelialization. So be careful when you use them. If you know why you're using them, that's fine. The most frequent recommendation nowadays is if there is a Pseudomonas infection. But otherwise, I would not use these as primary wound care products. And a little bit about burns, because this was not covered in that broad overview. So managing a burns patient has a lot more to it than managing the burns wound. So the general principles of managing burns include the first aid when the patient comes to you, if there are inhalation injuries, if there are other critical injuries like burns to the hands, face, perineal areas, and the pain management and fluid resuscitation. But if you were looking at the wound dressings in burns, you want to, in the first 48 hours, you want to use a dressing that you can keep for the first 48 hours, because your first wound inspection is going to be in 48 hours. So you use a dressing that stays on for 48 hours, and you try to use something that has antimicrobial properties. So the commonest one we've used even historically has been silver sulfadiazine, and that's fine. So that's a good wound dressing for the first 48 hours. If you want to go a bit extra, you can use something like Acticoat, but make sure whatever dressing you use is non-adherent, because that skin is very delicate in the initial 48 hours, and the first dressing change, if you're not careful, will take off some good viable skin if you're not careful. So you inspect the wound after 48 hours, and these are, mind you, small wounds. These are wounds that can be managed in a primary care setting. These are not wounds that needs hospitalization. So after 48 hours, we generally tend not to use silver, because there are studies that show silver inhibits keratinocytes and fibroblasts. So you might actually prolong the healing by using silver for a long period. So this is the time where you need to give the wound moisture and a control level of moisture. So you can use foam dressings, hydrocolloid, and hydrogel. So film dressings are very useful if you have wounds that are very superficial, doesn't have much exudate. The problem with them is they have zero absorbent capacity, so you have to use them only in appropriate settings. So if it's a superficial abrasion and you don't want much absorption, you don't expect any exudate, go ahead and use a film dressing. Also, like the previous setting where we use foam dressings, where they won't stick by themselves, you can use a film dressing to keep them in place. Okay, so that is how to select the wound dressings, and I don't think we have much time. So these were the characteristics of separate dressing. I'll quickly go through them, but now I've told you the main concerns about how to choose a dressing. So hydrocolloids and hydrogels, they maintain the moisture. The good thing is that you can leave them for a few days. So you don't cause repeated tissue injury when you're using them. The problems is if the hydrogel spreads beyond the wound, there can be maceration from the wound fluid that is come. So I think my time's up. I will stop. There might be questions. So if you have any questions, please feel free to email me, and I can answer any questions if there is any from the audience or the speakers, audience at home.
Dakshit, can we ask you to join us here? I think there are some questions online. Thank you very much for that very graphic demonstration of wound care, which I think which was tailored towards primary care, and I'm sure our membership and the audience have benefited from it. I think you have a few questions on.
There's one question.
Can you just take that, Dakshit?
What about papaya therapy for necrotic slough?
Okay, so papaya has, or raw pepper has papain, which is an enzyme that helps lysis of tissue. The problem is we don't have any commercial preparations. Sorry, I hope you heard that. The question was about papaya. So it's papain, the enzyme. The problem is we don't have any commercial preparation that is available that has this. So as the MBBS doctors, the SLMC prohibits us from using any other medicine that has not been scientifically validated. So I can't recommend them on those grounds, but the action is enzyme, lytic action of papain, and I have seen situations where it has been used to good effect.
Can you just check whether there are any other questions, Dakshit, if you don't mind?
No, I think that's
So in the absence of any other questions, on behalf of our virtual audience and on behalf of the college, may I thank you for your presence here today.
Thank you very much.
And express our gratitude to you with a small token of appreciation.